Good evening, everyone, and thank you for joining us for the month of April's Student Educational Talks. We appreciate you all joining us this evening, and we're happy that you're able to attend this. I did want to go ahead and start off with our professional student organization mission statement. Our focus is to offer an international community for healthcare students with passion in oncology and pharmaceutical industry. We provide education, leadership, mentorship, and opportunities in research and community outreach. We promote unique and dynamic experiences for students to collaborate with all oncology stakeholders. First, I wanted to welcome all of our established NCODA PSO chapters. So we currently have 28, and those consist of South University, University of Rhode Island, Midwestern University, North Texas University, Washington State University, Texas Tech University, Purdue University, Nova Southeastern University, Massachusetts College of Pharmacy and Health Sciences University, the University of Minnesota, University of Toledo, Albany College of Pharmacy and Health Sciences, University of Iowa, Lake Erie College of Osteopathic Medicine, Auburn University, University of Missouri, Kansas City, Binghamton University, University of New Mexico, Belmont University, Wingate School of Pharmacy, University of Florida, University of Utah, Howard University, Temple University, Shenandoah University, Oregon State University, the University of Toronto in Ontario, Canada, and the University of Colorado. So welcome all established NCODA professional student organizations. We also wanted to welcome all in progress NCODA professional student chapters. The student educational talks are open to all students regardless of their membership. Thank you for joining in this evening. Welcome all students. Currently, we're 3,300 plus members and 620 plus practices strong. Working together, we become stronger. I want to let everybody on the call know, if you want to stay up to date, follow our Facebook and Instagram pages. I'll go ahead and leave it here for a few seconds, and that way if you take out your cameras and scan both of those QR codes, you should find our social media websites. As well as if you have the time or if you're on LinkedIn, feel free to follow our national NCODA page for all of our latest information and news regarding all of our initiatives. And for those of you who have not signed up for our 2021 Spring Forum, the first day was today. It was a massive success. We had some great speakers. There is still time, so if you have not had the chance to register yet, you can still go ahead and register, whether it's this evening or tomorrow, and that way you can still join us for the next 2 days of wonderful presenters. I would now like to turn it over to our first presenter of the evening, Mary Alice Anderson, a pharmacist with Cancer Specialists of North Florida. Mary, I'll turn it over to you.
Hi, can everyone hear me?
Yes, we can.
Okay, great. Good evening. So I'm Mary Alice. I graduated in 2016 from University of Florida, and I am currently the research manager at Cancer Specialist of North Florida. So I wanted to really, when I came into this role, I came from a retail setting, and I really had a lot of questions in retail with over-the-counter with cream, sunburns, since I'm in Florida. And so when I transitioned into the role of a pharmacist at Cancer Specialist of North Florida, what was so interesting to me was I was still getting really similar questions, and it came from our radiation patients who, and I'll talk a little bit more about it in this conversation, in the presentation, but really they were presenting with similar things I was seeing over the counter, because radiation ultimately can be similar to getting a very severe sunburn. So I created this presentation just to give to our students so that they would have the tools to counsel patients who are experiencing acute reactions as a result of radiation. But the beauty of it is you can really apply these counseling tips to a lot of different patients who will present to you in numerous settings, including retail. So going into that, wanted to give an overview of radiation therapy, review radiation toxicities, look at the presentation and management of radiation-induced dermatitis, mucositis, and xerostomia. And it's been a long day, so I don't want to butcher anything, so I'm just going to say it's pretty much dry mouth, and then understand what your role as the pharmacist is. So radiation therapy, more than 50% of cancer patients are going to receive radiation therapy. It's an essential component of adjuvant, neoadjuvant, and palliative therapies. So I'm not sure where all the students are with their training, but just for completeness sake, adjuvant is going to be radiation giving after any kind of treatment modality. That can be chemotherapy, surgery. Neoadjuvant is going to be radiotherapy given before any kind of treatment. Palliative is just to alleviate symptoms such as bone mets, spinal cord decompression. So with radiation, ultimately, you have X-rays and gamma rays that cause breaks in the DNA and generate free radicals from the cell water. So what it does is it makes the cancer cells unable to repair the damage. And the beauty of radiation and where science is going is the collateral damage that we used to see, we aren't seeing as much anymore, meaning that we are able to give very targeted radiation therapy. So we aren't seeing as many of the side effects because it is so calculated to the specific cancer cells. However, we still will see collateral damage. We aren't perfect. And so you're causing breaks in your DNA that generate free radicals from cell water. It's going to be augmented by oxygen, meaning your hypoxic cells are going to be more resistant. Something that I also find really interesting is that non-dividing cells are also going to be more resistant than your dividing cells. So it then would make sense that you are getting the side effects in your mouth, which is a high turnover cell. And then you'll also see patients with GI side effects. And so it's just really interesting when you keep that to heart, is the fact that this radiation is really going to be targeting your dividing rapid turnover cells. I'm not going to go too much into the different types of radiation therapy because I'm by no means a radiologist. So radiation toxicities. So it's going to be dependent on your total radiation dose, dose fractionation, schedule, and volume treated. So really, it depends on the different cancer types, and I'm not going to go too in depth with it, but for some cancer types, you will see patients will receive radiation 5 days a week on weekdays. And so that's going to then impact the type of side effects they have. So ultimately, your injured tissues are going to release cytokines, and your organs requiring cell renewal are most sensitive. And the nomenclature is a little different. You pretty much have acute, subacute, or chronic toxicity, and then that can be kind of divided further into your early effects and late effects. So the early effects are going to be more acute in nature, and then your late effects are going to be more in lines of like fibrosis, ulceration, and more long-term effects. So first, going into radiation-induced dermatitis. It's experienced by about 95% of your radiation therapy patients. So this is really where I'm talking about this. It looks like a sunburn. It's actually very interesting. So you do have patient-related risk factors. So for instance, a smoker, poor nutritional status, diabetes, pre-existing connective tissue or autoimmune disease, excessive skin folds, they're going to have a greater risk of having this type of acute reaction. So it's a combination of direct radiation injury and then the subsequent inflammatory process. It can manifest days to weeks after the start of therapy. And also you have to keep in mind some chemotherapy, such as doxorubicin, 5-FU, bleomycin, those are going to be radiosensitizing, meaning they're going to make you more prone to having these type of reactions. And then also you have to think about the type of cancer. So a breast cancer, because usually the site is where two skin surfaces are meeting, they're going to be also more likely to have a dermatitis reaction, and also in the buttocks. And it's usually evident 1 to 4 weeks after the start of the therapy. And it is going to affect the stem cells within the basal layer, preventing the process of repopulation and weakening integrity of the skin. So early, at first, it's going to kind of look red, dry, and then it gets moist. And then later on, you're going to start to see the pigmentation changes and ulceration. So here's some photos. We grade the level of reaction based off of the NCI, CT, CAE. This is pretty common terminology and a grading scale for a lot of the different types of adverse events experienced with chemo and radiation. So grade 1, it's going to be slightly red and dry. And if you don't take anything home from my presentation other than if you have a dry, any kind of skin reaction, please use an ointment. Do not use a cream or a lotion. Ointments are going to be occlusive, so it's going to keep the moisture in the skin. That is one of the biggest take-home messages I ever took from my compounding class in school is dry, use an ointment. If I have cracked lips, I'm using an ointment. So that's where you can see with the moisturizers, they're going to be petrolatum-based or ointments to keep the moisture in to prevent irritation. You can do some anti-itch and rash. So a topical hydrocortisone. Sometimes it can require some oral therapy, such as like hydroxyzine or corticosteroid or Benadryl if it's very itchy. But at this point, you're just trying to help manage the symptoms. You can do a topical anesthetic like Emla or lidocaine to help if it's starting to become painful. And really, like I'm saying, with the dressings at this point, you want to do, you want to think keeping moisture in. So you're going to do a wound dressing that is going to be wet. Okay, and so also, and at our practice, this is what we'll do is we'll give wound care and debridement. So there's these wound kits and it's going to have saline, gauze pads, and then it'll have Silvadene cream. And so that's really what you'll have them do is they'll soak the area. And this is really just, again, to moisturize and prevent it worsening down the road. Then you start to get to your grade 2 and 3 dermatitis. So it's going to start getting a little more red. And this is where you're going to start seeing it becoming moist. So, and you can start to see the moderate edema. So I like to kind of, just to bring it home and bring a visual, I like to have my students visualize it as if you've ever taken something out of the oven and you touch a really hot pan, that it's going to look like that kind of wound. So it's where it looks like it's almost kind of pussy underneath. So, and then that helps to bring it home on how would you want to treat it. So at this point, it's usually a little more on the wet side. So you're going to want to do drying. So at this point, you can start to suggest creams and lotions. You do want to stay and transition away from the ointments. And then you can start to get grade 4 dermatitis, which is the more severe, and you form ulcers and necrosis. And you can use an oral pentoxiflin. I've never seen this in practice, and there's not a lot of evidence to truly support it. Unfortunately, there's not a lot of oral options for it. And then you do have to remember that if you have breakage of the skin, you may require antibiotics, antifungals, or antivirals, depending on how it presents. Okay, and so this is another really important slide, the topical corticosteroids. I used to get asked on the reg, hey, what is a medium potency? What's a high potency? What's a low potency steroid? I'd always have to look it up. So I made this chart finally. So a lot of times your physicians will ask you to remind them what are the different potencies of your topical steroids. There is, with your topical steroids, proven anti-inflammatory effects that inhibit the upregulation of cytokines. Truthfully, though, there's limited and conflicting data on whether patients benefit from prophylactic use. So I typically recommend only using them for symptom management. So counseling, this is where, as a pharmacist, I think we're extremely helpful. Maintaining good hygiene standards. You want your patients to be using pH neutral cleansers, Dove, baby soap, Neutrogena, wash skin daily. Make sure they do not apply lotions or topical products right before radiation therapy about 4 hours, because it can cause a bolus effect and thicken the skin. So it's going to then increase the surface dose of radiation, and that's not what you want. Also, probably avoiding things with perfumes, alcohols, anything that's going to irritate the skin. So now moving on to radiation-induced oral mucositis. So this is seen in about 50% of your radiation therapy patients, mostly in your head and neck, abdomen, or pelvis cancers. Again, there's patient-related factors. So poor nutritional status, poor dental hygiene, dental cavities, smoking, alcohol, chew tobacco, that's all going to potentially make this worse for patients and increase their risk. So a lot of times our physicians will require an upfront dental exam to make sure that they are all checked off and everything's been addressed in the mouth before receiving any therapy to the head and neck. So this is, again, you have a direct injury and then you have a multi-phase inflammatory response. This typically manifests about 2 weeks after the start of radiation. And then you can see here, this actually is graded not by the NCI, it's the World Health Organization's toxicity scale, and you can see the worsening in the picture. So management, differential diagnosis is actually very important here, because you want to make sure that you aren't missing an underlying condition. So for early or unusually severe mucositis, especially if there's a concurrent skin reaction, you need to rule out HIV or collagen vascular disease. Also note that Candida can present in an atypical patchy fashion. So if in doubt, treat it, but then also consider proton pump inhibitor. So again, kind of similar to your dermatitis, you want to help with symptom management, topical agents, And unfortunately, again, no drugs are really approved to reduce duration, incidence, or severity for patients with solid tumors. There is one option for patients with hematologic malignancies, but I've never seen that prescribed. And so here's some of the products. You can do sucralfate. So what that's doing is it's literally coating the mucosa and protecting it from the irritants. So you can see the carafate suspension. That is a huge component, or that our physicians do like to prescribe that a lot. You have the chlorhexidine, which is going to suppress your oral flora. So swish 30 seconds. That that's pretty commonly recommended, especially if they have any kind of like lesions. And again, like I was saying, a proton pump inhibitor, because it's inhibiting your gastric secretion, so it's going to prevent irritation of those open wounds. And then you can do topical anesthetics. The magic mouthwash, our physicians really like it. There's no clinical evidence of benefit. However, you know, if a patient's really in pain, you do want to give them something to help. There's, in my opinion, there's a huge mental component also for these patients. So sometimes just giving them something can be very beneficial and helpful. And then, of course, you have to be very careful once you have the lesions to with watching for infection and candidiasis. So I've just listed some commonly prescribed antibiotics and antifungals, but I'm not going to go too in depth there, because if you're in pharmacy school, you get this a lot. Counseling. So again, as a pharmacist, I firmly believe in counseling. It's a huge mainstay in prevention. So ultimately, you want your patients to have really good oral care. It's going to reduce the oral microbial flora. It's going to reduce pain and bleeding, and then it's going to prevent infection. So, the recommendation: soft bristle toothbrush twice daily, minimal flossing, avoid alcohol, tobacco, irritating foods, avoid mouth rinses containing alcohol. And let me tell you, that is really hard to find a mouthwash that does not contain alcohol. So a lot of times recommending a baking soda or saline gargle is your best option. And then you can also try neutral or mild toothpaste such as biotin. So radiation-induced dry mouth, it's the subjective complaint of dry mouth. So you have a salivary gland dysfunction from the tissue damage from the radiation. So your salivary flow decreases by about 50 to 60%, usually within the first week, and it can worsen up to 6 months, then improve, and it can take up to 3 years. So it's going to be dryness, burning sensation in tongue, fissuring of tongue and lips, dental cavities, and increased thirst. So unfortunately, management isn't, there's not great options out there. You can do artificial saliva, baking soda gargles, avoiding, again, alcohol containing mouthwashes, and then you can recommend moisture stimulants, biotin chewing gum, sugar-free candy, sometimes even ginger is helpful. And then those miscellaneous, so pilocarpine is a cholinergic agent. It has been proven to effectively stimulate salivary secretion and increase your quality of life. However, there are a lot of side effects with it, such as sweating, GI upset, flushing, and urinary frequency. And then you don't want to recommend it in your patients with cardiovascular disease, glaucoma, uncontrolled asthma. So Really, I think that as a pharmacist, the biggest impact we can have is doing med reviews. So looking for those medications that can actually worsen your dry mouth, such as anticholinergics, opioids, antihistamines, decongestants, antidepressants, antidiarrheals. So really just helping to get that med list streamlined a little bit, especially because these patients can be on a lot of different medications, and just having conversations with them and, pros and cons, and letting them know that this could be potentially worsening their dry mouth. And that is all I have. I don't know if anyone has any questions or there's time for that.
Yeah, I believe we have a time for a few questions if anybody wants to come off mute or just type it in the chat box. I did have one for you, Mary. Do you ever recommend like urea-based creams or ointments?
I could see where, so not in the pharmacy that I used to work in at Cancer Specialist of North Florida, but that's probably something I could add to the presentation. I know that sometimes, like, I know now there's some that are over the counter, but the more prescription strength ones, they can be hard to get covered by your insurance. So that would be, I could definitely research that and add it, because that's a good point.
Yeah, I just know that a lot of times that's what's recommended for like hand and foot syndrome and other dry cracking side effects and things along those lines.
Yeah, I think that with chemotherapy though, the skin issues, they present a little differently. So it's not necessarily like that dry cracking you really get with hand foot. So it really looks more like a sunburn. So it's more the redness and dryness. I don't know if that makes any sense.
Nope, it definitely makes sense.
I have a quick question for you. I was just wondering how you handle patients' anticipatory fear for these side effects, because I wouldn't be surprised if patients are aware that these might happen to them and then it would therefore delay their treatment.
Absolutely, that's a great question. And even for a lot of patients who are receiving radiation therapy, if you're claustrophobic, it can be very difficult for them. So really, that is something our radiologists are really good at managing. So they will prescribe, if needed, maybe a benzo to help with the mental component of radiation. And then so sometimes maybe your first cycle you really did have an awful reaction, and then you have to continue going. So our radiologists at our practice are all incredible and really good about helping guide patients through that.
Perfect, thank you.
All right, thank you so much, Mary. I would now like to turn it over to our next presenter, Julie Polka. She is a senior clinical oncology specialist with Genentech, and her main specialty is with Venclexa.
Hey everybody, can you hear me? I hope you can hear me.
Awesome. Yes, we can, and we can see the slide
okay.
too.
And you can see the screen. Okay, great. So hi everybody. I know this is probably at the end of the day for you and everybody's probably exhausted, so I'll try to give you as much information as I can about Venclexa and acute myeloid leukemia. So this is great news for these patients. Venclexa right now is indicated in combination with azacitidine or decitabine or low dose, sorry, my dog is barking, or low dose cytarabine for the treatment of newly diagnosed acute myeloid leukemia patients in 75 years or older patients who have comorbidities that preclude use of intensive induction chemotherapy. So this is actually really important because there are patients that can't be treated with intensive induction chemotherapy. And those patients can now, typically they would be given azacitidine, decitabine, or low dose cytarabine. And now you can add Venclexa to that. And you can see here in just this first page, the VALIA trial was our phase 3 trial for Venclexa and azacitidine, and it really proved to help these newly diagnosed AML patients live longer. And as you can see, the median overall survival for azacitidine was 14.7 months versus placebo plus azacitidine, so azacitidine monotherapy at 9.6 months. So it's really 5 extended months for these patients. And that could be another birthday. It could be seeing, because keep in mind, these are older patients, could be another anniversary with their husband. It could be another grandchild, being born. So it is, it's important for these patients to have another option. The NCCN Guidelines, which I'm sure you are aware of and familiar with, they recommend venetoclax and azacitidine as the only category 1 preferred agent in these patients with or without actionable mutations. So we will go through some of the mutations that were seen in this study, but that's also going to be an important factor. So we'll go on to the next page and look at the study design. So basically, the patients were randomized on a 2-to-1 basis. Venclexa was dosed 400 milligrams orally once daily, but there's a 3-day ramp up of 100 milligrams on the first day to 200 milligrams on the second day, and then a final dose of 400 milligrams on the third day, and then you continue on at 400. That's continued for 28 days for the first cycle, and then azacitidine is given 75 milligrams per meter squared, either IV or subcutaneously, on days 1 through 7. And that's beginning day 1 of each 28-day cycle. The other arm of the study was placebo, orally once daily, and then azacitidine at 75 milligrams per meter squared, IV or sub-Q. And these treatments were continued until disease progression or unacceptable toxicity for these patients. So we did look at several different endpoints. The primary endpoint was overall survival in these acute myeloid leukemia patients. And the select secondary endpoints were CR, CR and CRH, and CR and CRH by initiation of cycle 2. The important thing to remember here is some of the patients after the first cycle will have remission, and some of them at cycle 2, cycle 3. I'm not sure, I'll go through what the definitions are. CR is defined as an absolute neutrophil count of greater than 1,000 microliters, platelets of greater than 100,000. The red blood cell transfusion independence is another part of complete remission in these patients, and bone marrow with less than 5% blasts. And the complete remission with partial hematologic recovery was defined as less than 5% of blasts in the bone marrow, no evidence of disease, and partial recovery of the peripheral blood counts. Some of the comorbidities, so when you talk about a patient that is greater than 75 years or has comorbidities, these comorbidities are based on at least one of the following criteria, as you can see down here: a baseline ECOG performance status of 2 to 3, creatinine clearance of less than 45, severe cardiac or pulmonary comorbidities, other comorbidities, or moderate hepatic impairment. And we'll take a look at the baseline characteristics of these patients. Some of the important call outs here, there's a couple. Well, the median age was 76 years old, and the ECOG performance, 45% of the patients had an ECOG of 2 to 3, and 100% of these patients were intermediate or poor cytogenetic risk. And if you take an even deeper dive into these patients, you can see the ECOG performance status here, 45%, bone marrow blast, disease history. Here again is the cytogenetic risk. And here is the mutation analysis detected. So this study included all patients with IDH1 or IDH2, IDH1 separately, IDH2, FLT3, NPM1, and TP53. So it really did have a good real world patient population for this study. And sorry about this, but sometimes I have, there we go. So then we'll move on to the next page and look at the efficacy data. So as you can see here, this again is going through what we talked about on the first page, but really Venclexa and azacitidine demonstrated really superior overall survival data in these patients. The primary endpoint again was the overall survival, and you can see really in this Kaplan-Meier graph the difference in median overall survival here is really showcased here with 14.7 and 9.6, but these patients are really going out. Median follow-up for overall survival was 20.5 months. There was a 34% reduction in risk of mortality for these patients. And when you can take a look at the biomarkers, but overall survival in the IDH1 and IDH2, that was a pre-specified secondary endpoint, and 65% had a reduction in risk of mortality in this group. And then if you take a look at the additional subgroup data, you can see here's the overall survival that we talked about, and then all the biomarker subgroups. So moving on to some of the complete remission information for these patients. There really was almost 3 times more remissions in the patients that had Venclexa added to azacitidine versus azacitidine alone. There was a longer duration of response and greater transfusion independence for these patients, which we all know, I mean, transfusions means the patient are going in for multiple appointments, and the quicker they can be transfusion independent, the quicker they can get back to a normal life as much as possible. So if you take a look at here, I mean, 65% of the patients had a CR, CRH, 18 months for duration of response in these patients on average. And over here, you can see azacitidine alone, 23% of the patients had a CR, CRH score. And on average, the duration of response lasted for about 13 months. We did break out some of there's a M14-358 study, and this basically looks at Ven plus azacitidine or Ven plus decitabine, which is another option for these patients. Again, we do our Venclexa dosing orally once daily, and then add either azacitidine at 75 milligrams per meter squared, or in the other arm, you have decitabine 20 milligrams per meter squared. 67 patients received Ven-Aza and 13 received Ven-Decitabine. And of course, they were greater than 75 years of age, or they met at least one of the following criteria for comorbidities. The treatment again was continued until disease progression or unacceptable toxicity. And then you have Venclexa, which is Ven plus LDAC. And here's additional efficacy from this trial. And you can see the efficacy based on the rate of CR and the duration of CR. The rate was 27% with Ven-LDAC versus 7.4% with placebo, basically LDAC monotherapy. The duration of response was 11.1 months with Ven plus LDAC versus 8.3 months. Complete remission and complete remission with partial hematologic recovery was 40%, 47% with Ven plus LDAC versus 15% with LDAC alone. And the duration of response was 11.1 months again versus 6.2 months. We have talked about dosing, but we'll talk a little bit about the pre-treatment of these patients and what to watch out for. So you, of course, in these patients, you want to really assess the level of risk of TLS and provide prophylactic hydration and anti-hyperuricemics to patients prior to first dose of Venclexa to reduce the risk of TLS. Pre-treatment for TLS risk assessment, you definitely want to look at the white blood cell count, and it needs to be less than 25 times 10 per liter prior to the initiation of Ven, and cytoreduction prior to treatment may be required. Prior to the first Venclexa dose, you definitely want to have adequate hydration for these patients and add anti-hyperuricemic agents and continue them through during the ramp-up phase. So that's day 1, 2, and 3. Assess blood chemistries and correct pre-existing abnormalities. Monitor the blood chemistries for TLS. So you want to do that before you start Venclexa, then 6 to 8 hours after each new dose during ramp up, and then 24 hours after reaching the final dose. So again, here's the dosing so you can see it. Day 1, you start these patients at 100 milligrams, day 2, 200, day 3, 400, and then day 4, 400 milligrams times for 28 cycles, 28-day cycle. 3-day dose ramp up phase, and then you continue Venclexa in combination with azacitidine until disease progression or unacceptable toxicity. And then of course, azacitidine, 75 milligrams per meter squared, days 1 through 7 of each cycle. There are dose modifications for these patients based upon certain medications that they also may be on. So I'll go back to this. Venclexa is metabolized through the CYP3A enzyme, and so the dose should be reduced when you're using PGP inhibitors or strong or moderate CYP3A inhibitors. And here are the dose modifications for Venclexa. So for example, if the patient's on posaconazole, you have a different initiation ramp up. Day 1, you start 10 milligrams, day 2, 20, day 3, 50, and then day 4, 70. And you reduce the dose of Venclexa to 70 milligrams continuing for a daily dose. Other strong CYP3 inhibitors, similar initiation and ramp up phase, but you reduce the Venclexa dose to 100 milligrams after the ramp up phase. And then moderate CYP3 inhibitors and PGP inhibitors, you reduce the Venclexa dose by at least 50%. And the safety for these patients, many of the hematologists, oncologists that I've spoken with that have used Venclexa in these patients, they know this safety profile and understand it. It's a very tolerable and manageable and predictable adverse reaction profile. There's no new additional warnings or precautions for Venclexa in the AML trials. But if you take a look at, so the most common all grade adverse reactions are nausea, diarrhea, febrile neutropenia, musculoskeletal pain, and fatigue. Grade 3 or 4 in the Ven-Aza arm is febrile neutropenia, sepsis, and hemorrhage. Similarly, over in the azacitidine, you can see the all grades and grade 3 and 4. So when you take a look also at the lab abnormalities, new or worsening grade 3 or 4 in VLEA with a difference between arms of greater than 2%, the callouts were neutrophils decreased 98% of the patients versus 81% in the AZA alone. Platelets decreased 88% versus 80%. lymphocytes 71% versus 39%, and hemoglobin decreased 57% versus 52%. So these are definitely things that this is why you are constantly monitoring, just to make sure you're able to treat these patients properly. The duration of exposure in the Ven-Aza arm versus Aza alone, median duration was 7.6 months that these patients were on therapy, and the range, I think, was between 0.1 and 30 months. And for Aza alone, 4.3 months. And the mean number of cycles in these patients, so the full dosing of one cycle, there were 7 cycles in the Ven-Aza arm versus 4.5 in the azacitidine alone arm. And here is the occurrence of adverse reactions in Ven-Aza and placebo Aza arms. I'm gonna increase this so we can take a look at this. So 83% occurrence of serious adverse reactions, and the most frequent adverse reactions, again, the call it is febrile neutropenia, pneumonia, sepsis, and hemorrhage. And the most frequent adverse reactions in Aza, pneumonia, febrile neutropenia, and sepsis. Fatal adverse reactions, 23% occurrence, and those were in 2% of pneumonia, or pneumonia 4%, sepsis 3%, and hemorrhage 2%. When you look at the azacitidine alone arm, you see sepsis at 4% and pneumonia at 2%. This is a very important part of when you look at these adverse reactions. What is the discontinuation rate? What's the reduction rate of Venclexa? And what are the interruption rates? So in the Ven arm, adverse reactions leading to a permanent drug discontinuation, 24. Most frequent adverse reaction leading to dose reductions, 3, and it was in pneumonia. And dose interruptions were in 72% of the patients. But I think this is really important to point out that there were dose interruptions, but only 24% of the patients had drug discontinuation. So the patients are really, 75% of the patients are still able to continue their treatment on the Ven-Aza arm. Okay. So this is looking at response rates at different times throughout treatment and the management of the grade 4 neutropenia or thrombocytopenia. We'll go through the 3 different screens down here, but so in the VLEA study, bone marrow assessment was conducted following cycle 1 treatment. And once the bone marrow assessment confirmed a remission, then Venclexa or placebo was interrupted up to 14 days, or until the absolute neutrophil count greater than 500 or platelet count greater than 50 times 10 microliters. For patients with resistant disease after the end of cycle 1, a bone marrow assessment was performed after cycle 2 or 3 and as clinically indicated. So these are the secondary endpoints. Clinical remission, so 105 patients were in clinical remission and the Ven-azacitidine versus 26 in the placebo arm. The duration of response was 18 months in the Ven-azacitidine versus azacitidine alone at 13 months. The time to remission, so then they looked at the patients and they looked at secondary endpoints, but CR/CRh by initiation of cycle 2. 40% of the patients were in remission with Ven-azacitidine. And then they did an exploratory post hoc analysis to look at these patients. And at cycle 3, 47% of the patients achieved a clinical remission or a CRh. And at cycle 4, 50% of the patients achieved a complete remission or CRh. So when you're looking at this data with complete remissions at cycle 2 and then at cycle 3 and cycle 4, How then do you dose modify these patients depending on where they are in their clinical remission? And that's really important for AML patients because it's different than how you treat a CLL patient and an AML patient. So with AML patients that have a grade 4 neutropenia with or without fever or infection, or grade 4 thrombocytopenia, they recommend that the occurrence before remission is achieved. So if you have a grade 4 neutropenia or a thrombocytopenia and the patient hasn't had a clinical remission yet, that the patient stay on Venclexa. So in most instances, do not interrupt the Venclexa regimen due to cytopenias. If the patient has a clinical remission, then occurrence lasting at least 7 days, you delay the subsequent cycle of Venclexa and monitor the blood counts. So for the first occurrence, so a patient that has first occurrence in their cycles of neutropenia or thrombocytopenia, you're going to resume Venclexa therapy at 400 milligrams in combination with azacitidine or decitabine at 600 in combination with low dose cytarabine upon resolution to grade 1 or 2. So you can resume Venclexa at grade 1 or 2 and resume 28-day cycle treatment. If you have more than one occurrence, you resume your Venclexa therapy upon resolution of the grade 1 or grade 1 or grade 2, and you reduce the treatment cycle by 7 days. So instead of the next cycle being 21 days, you reduce the treatment to 21 days. And then for your grade 3 or 4 non-hematologic toxicities, any occurrence, you interrupt Venclexa if not resolved with supportive care. And upon resolution to grade 1 or baseline level, you can resume Venclexa. One of the things that we talk a lot about, and especially if we're treating patients that are greater than or equal to 75 years or have comorbidities, they possibly may need patient support services. And we have so many resources available to help these patients and support them through their chapters of their treatment journey. We have patient support services, patient access services to help them pay for their medication. And so here's just the overall summary. But again, for these patients that need another option instead of intensive induction chemotherapy, adding Venclexa to azacitidine really can give an opportunity for these patients to live longer and enjoy a little bit more time with their family. So that's the presentation. If you guys have any questions or anything you might need, I'm happy to help.
Yeah, thank you so much, Julie. We appreciate your presentation over Venclexa. It seems to be helping a tremendous amount of patients. The one question that we had come up was regarding the mutations. I know we discussed the IDH, the FLET, those different mutations. Was there any specific mutation where this combination regimen really showed a lot of benefit, or inverse, where a certain mutation might have caused a lot more side effects?
Well, so the benefit definitely in efficacy, you can see here that there was a statistical significance in the consolidated IDH1 and IDH2 group of patients in the Ven-Aza arm. So for that group, you could definitely see a significant statistical significance in 65% of the patients, the reduction in risk of mortality. They did include really all of the mutations in this study, and so the overall survival proved to show a difference for these patients. The overall survival in FLT3 did not meet statistical significance. So that's one subgroup that they looked at. but I don't know that it means that you cannot use it in those patients. It just, in the study, the way that it was powered, apparently it just did not show statistical significance in these patients. And as far as the safety, I don't know that they broke out mutationally what how those patients looked, but I can have I'm pretty sure our medical science liaison might have that data that we could forward on to you, but or maybe Austin, she can call you and talk to you about that information, but I don't have that in here. Is that what you were asking?
Yeah, I was just kind of looking to see if there was going to be any mutation where there might be a little added benefit, or again, the inverse where a little more side effects or less of a reaction. And I think you answered that. I think seeing the FLT not being statistically significant.
Yep.